That ringing, buzzing, or whooshing sound that nobody else can hear but you just can't escape. If that's what you're dealing with, I want to start here. You're not imagining that, and you're not crazy. And you're not wrong for wanting a better explanation than just hearing it's just tinnitus, because naming it doesn't explain it. What does tinnitus actually mean? Why does it start? And why does it completely take over one person's life and barely register for another person's life? And if it's coming from your own auditory system, what can you do about it?
If you're navigating hearing loss or struggling with ringing in your ears, then you've come to the right place. The All Ears Hearing and Tinnitus podcast is your go-to source for expert insights, real stories, and cutting-edge solutions in hearing health. We'll dive into the latest advancements in hearing healthcare, explore groundbreaking treatments for tinnitus, and offer practical tips for better hearing. Here to help you tune into a world of better hearing, here's your host from Timpanogos Hearing and Tinnitus, Dr. Layne Garrett.
I'm Dr. Layne Garrett, founder of Timpanogos Hearing and Tinnitus here in Utah. I spent over 20 years evaluating and treating tinnitus, and it's one of the most misunderstood conditions that we work with. People come in having been told everything from, you'll just have to learn to live with it, or you just have to ignore it. Neither answer is good enough, and neither one starts with actually understanding what tinnitus is. So that's what we're doing today, the real explanation. Tinnitus is the perception of sound when there's no external source producing that sound. Your brain registers sound, real, vivid sound, and nothing in the environment is causing it. Most people assume that tinnitus is an ear problem, and it does often begin there. But what we now understand is that tinnitus is ultimately a brain and nervous system problem. The ear may start the signal, the brain decides how loud, how important, and how threatening that signal feels. Here's the mechanism. When your auditory system gets disrupted through noise exposure, hearing loss, medication, or other damage, the brain doesn't just go quiet, it compensates. It turns up its own volume knob, trying to fill in the missing sound information. Sometimes it turns that knob up so high that you perceive sound that has no source in the outside world. A 2024 review published in Brain Sciences described this as the brain rewiring itself in a way that generates phantom sound perception rather than helping you. Phantom here is the right word. Tinnitus is not imaginary, it's a real neurological activity. It's just not coming from the world around you, it's coming from within your own auditory system. Not all tinnitus is the same, and that distinction is important. Most tinnitus is what we call subjective. Only you can hear it. It's generated internally, it can't be measured with a microphone, and no examiner can detect it directly. This is the most common form of tinnitus by far. But there's also objective tinnitus, which is much rarer. This is the type of tinnitus that can actually be heard by another person because there's a physical source producing real sound. Usually that's vascular, blood turbulence from a blood vessel that's near the ear, or it can be muscle spasms in the middle ear. And with those categories, you'll hear about pulsatile tinnitus. That's tinnitus that often pulses rhythmically in sync with the heartbeat. If your tinnitus is pulsing with your heartbeat, especially if it's on one side, it's new or getting worse, that needs medical evaluation quickly. It can signal vascular or structural issues that need imaging. That is not the kind of tinnitus I'd simply monitor and manage. Get it checked by your doctor first. And while we're on those red flags, if your tinnitus came on suddenly, is in only one ear, or is paired with sudden hearing loss, dizziness, neurological symptoms, or ear pain, don't wait. Those need prompt evaluation, not a let's see how it goes kind of approach. Tinnitus is far more common than most people realize. A 2024 study published in the Lancet Regional Health Americas analyzed nationally representative United States data and found roughly 1 in 9 American adults, so about 27 million people, experience tinnitus. And of those, more than 40% report having tinnitus constantly. That's not occasional ringing after a concert. That's tens of millions of people living with a persistent sound every day. Risk increases with age. People with a history of noise exposure, whether military service, construction, live music, heavy machinery, they're at a significantly higher risk. And most people with chronic tinnitus have some measurable degree of hearing loss even when they don't realize it. That connection is not coincidental. It's a key clue about why tinnitus starts and how to treat it. So, what actually does trigger tinnitus? The honest answer is a lot of things, but they tend to share a common thread. They disrupt the normal flow of auditory information to the brain. The most common cause is noise-induced hearing loss. Loud sound damages the little nerve endings called hair cells in the cochlea. Those convert sound vibrations into signals that the brain can read. Once those hair cells are gone, they don't regenerate, and the brain is now receiving less input and starts generating its own sound. Age-related hearing loss works the same way. The gradual decline in cochlear function that comes with aging leads to the same kind of central auditory system or brain compensation. Other documented causes include ear infections, earwax impaction, certain medications like high-dose aspirin and some antibiotics, and chemotherapy agents are well-established culprits. And other health conditions like hypertension and diabetes affect circulation to the inner ear. Less commonly, structural issues like jaw joint problems, cervical spine issues, or blood vessels near the ear can produce tinnitus as well. A 2024 review in the Journal of Association of Research in Otolaryngology identified hearing loss, occupational noise exposure, ear infections, ototoxic medications, and depression as the main confirmed risks. Depression on that list is not surprising. A stressed and anxious nervous system notices tinnitus more, reacts to it more, and over time can make the whole experience feel bigger and harder to escape. This is what I hear more than anything else. My friend has tinnitus and it doesn't bother him at all. Why is mine taking over my life? Two people can have the same tinnitus, same pitch, same loudness, and have completely different distress levels. One person might notice it once in a while, the other can't sleep, can't concentrate, and feels anxious constantly. The difference is not the tinnitus itself, it's how the nervous system is responding to it. Tinnitus that becomes debilitating has typically gotten entangled with the brain's threat detection systems, the fight or flight response. Once the brain flags the tinnitus as dangerous, it pays more attention to it, and that amplifies awareness of it and creates a cycle that's very hard to break without help. Emerging research from Mass General Brigham found that people with debilitating tinnitus show measurable physiological signs of this chronic hypervigilant state. Subtle responses in the eyes and facial muscles, suggesting the nervous system is in a persistent threat assessment mode, even in everyday life situations. If tinnitus is affecting your sleep, your focus, or your mood, you're not overreacting. Your nervous system is doing exactly what nervous systems do when they believe something is a threat. The problem is the threat response itself becomes part of what keeps tinnitus so loud and so present. Just ignore it is not a treatment plan. You don't break that cycle by pretending that the tinnitus isn't there. So here's what most explanations of tinnitus leave out entirely. Tinnitus is treatable. Not curable in the sense that the underlying damage reverses, usually it doesn't. But the distress, the disrupted sleep, the inability to concentrate, the constant hyper-awareness, all of that can change substantially with the right approach. The treatment options with the strongest evidence are hearing aids when hearing loss is present, cognitive behavioral therapy, sound therapy, and tinnitus retraining therapy. A large 2025 multinational randomized trial published in Nature Communications found that these treatments can meaningfully reduce tinnitus burden, and the combination approaches showed stronger clinical effects than any single treatment used. Cognitive behavioral therapy and hearing aids both showed large individual effect sizes. The key takeaway isn't that everyone needs everything, it's that treatment should be matched to what's actually driving the problem in the person's case. Cognitive behavioral therapy deserves particular mention because it consistently shows the strongest evidence for reducing tinnitus distress. It's not about convincing yourself that tinnitus isn't there. It's a structured process of changing how your nervous system responds to the tinnitus, interrupting that threat cycle at its source. Hearing aids, when hearing loss is part of the picture, address the auditory deprivation that's often driving the patient's overreactivity in the first place. And for some patients, newer options like bimodal neuromodulation, pairing sound with a gentle tongue stimulation, are showing real promise for reducing tinnitus loudness, not just distress. If someone has told you that nothing can be done for tinnitus, they are not current on the research. Finding the right provider matters more than most people realize, and it's worth knowing what to look for. Primary care doctors and many ENTs are not tinnitus specialists. That doesn't mean they did anything wrong. Their job is typically to rule out medical red flags, and that's exactly the right first step when those flags are present. But for managing chronic tinnitus that's affecting your daily life, you need someone with dedicated tinnitus training. The credential to look for is the CHTM, the Certificate Holder in Tinnitus Management from the American Board of Audiology. This is not a simple weekend course. It requires demonstrated clinical competency in tinnitus assessment and treatment across multiple evidence-based approaches. Most audiologists don't hold that credential. Now, beyond credentials, ask the right questions. Does the clinic use validated outcome measures, tools like the Tinnitus Handicap Inventory or the Tinnitus Functional Index, to actually track whether treatment is working? Do they offer more than one treatment approach? Do they do proper hearing aid fitting using real ear measurements if hearing aids are part of the plan? The goal isn't to find someone selling the solution. The goal is to find someone who can evaluate your specific tinnitus profile and build a real treatment plan around it. A clinic that uses the same treatment on every patient is not doing the individualized care they should, regardless of how good their brochure looks. So drop a comment and tell me this. What were you told when you first asked someone about your tinnitus? I read all of the comments, and what people have been told or not told tells me a lot about where this field still falls short. And if you want to go deeper on treatment options and what a real tinnitus evaluation should include and what's worth your time versus what's just marketing, our free learning center has detailed breakdowns of all of this stuff. You can find a link to it in the description. And if you're here in Northern Utah and tinnitus is affecting you, you can schedule an appointment in one of our offices along the Wasatch Front. You can find a link to schedule that appointment in the description as well.
A world of better hearing and relief from tinnitus is within reach, and we're here to help. Be sure to subscribe to the podcast right now and join us on the journey to clearer sound and a richer life. Thanks for listening to the All Ears Hearing and Tinnitus podcast with Dr. Layne Garrett. We'll see you next time.